All right, I think we will start. Um, so, welcome everyone. My name is Zainab Naimi. I work at the Department of Maternal, Newborn, Child, and Adolescent Health in WHO headquarters in Geneva. Before we go ahead, we will, as usual, remind everyone of the house rules for the webinar, and I think Benna has also posted these at in the chat window. So as you enter the webinar, you're muted, so we only unmute speakers. After the presentations, we will have a question and answer session, but we encourage everyone to post your questions in the chat room while we are listening to speakers, so we make sure we note these down. And as you type them, please then send them to all panelists or all participants, so not just to the moderator or just the host. After the presentation, my colleague Benedict, she will moderate the question and answer session. So she will read out all the questions out loud, and then our panelists would have the opportunity to answer. And if we don't have time to answer all the questions today, then they will be shared with our panelists and answered on the network website in the following days. Um, so, as a reminder, the Network for Improving Quality of Care for Maternal, Newborn, and Child Health is regularly organizing webinars, and the latest series has focused on learning from the implementation experiences in countries that are leading the network. We want to learn how they've improved quality of care for mothers, newborns, and children, and what impact has been achieved. The previous series have been on how to do quality improvement in facilities, the importance of water and sanitation for quality care around childbirth, and how programs build and link to the national direction on quality. We've also launched a podcast called Quality Talks that Bene will tell you more about later. But coming back to today's webinar, we'll be hearing from Bangladesh about how they've adapted the quality of care standards for maternal and newborn health in health facilities. We'll hear about the experience from national level, so what process was taken, collection of baseline data, and what the vision is for quality of care going forward. We will also hear directly about work at the facility level, how facility teams got organized to do quality improvement work, and what their experience has been so far. Our speakers today is Dr. Aminul Hassan, who's the Deputy Director of Quality Improvement Secretariat at the Ministry of Health in Bangladesh, and Dr. Nazma, who's a Junior Consultant Gynecologist at the Narshindi Hospital in Bangladesh. So the floor is yours, Dr. Aminul and Dr. Nazma.
Mamoon, you can start the presentation now. We can't hear you.
Can you hear me?
Yes, perfect. Thank you.
Okay. Now I'm going to start. Okay. So thank you for joining us at this session. Greetings of the day wherever you are in the world, and thank you so much for your time. And I hope that by sharing of experience in Bangladesh, we are contributing to the global aims of improving healthcare. My name is Dr. Aminul Hassan, and I am the Deputy Director and Focal Person of the Quality Improvement Secretariat of Health Economics Unit of our Ministry of Health and Family Welfare in Bangladesh. I would like to introduce my colleague and co-presenter today, Dr. Kazi Nazma Begum. She is Junior Consultant of Gynae and Obs in the District Hospital Narshindi from our Director General of Health Services, as well as the Ministry of Health and Family Welfare. A number of development partners are supporting the efforts of Ministry of Health and Family Welfare to improve the quality of healthcare services in Bangladesh. Today's presentation, it is based on the initiatives taken by Ministry of Health and Family Welfare to adapt and adopt the WHO Quality of Care Framework for maternal and newborn health in Bangladesh. I take this opportunity to acknowledge the support received from ESID through Mamoni Health system strengthening project in these initiatives. Together, we'll take you through some slides to share our experience with you, and after the presentation, we'll be happy to respond to any question that you may have. Let me begin by sharing with you the health service delivery structure in Bangladesh. The slide on the screen shows you the structure. First, at the national level, we have the postgraduate teaching institute. At the same time, there are some alternative medical hospital and some family planning institute, which are located in the national level. And in the divisional and regional level, we have some medical college hospital and specialized hospital. All are the tertiary level hospitals situated in the divisional and regional level. At the district level, we have some district hospital as well as some mother and child welfare centers, which are managed by the Director General of Family Planning. Next, at the Upazila level. In the Upazila level, we have Upazila health complexes, which provide health and family planning services at the sub-district level. Next, the union level. At the union level, there are union health facility, union health and family welfare center. In a few of these unions, there is also a union sub-center or a rural dispensary. And at the lowest tier of the system, we have community clinics at the community level. The community health workers are known as the health assistant and family welfare assistant, who are responsible for providing outreach and domiciliary services. As you can see, we have a comprehensive and integrated healthcare system that spans across the continuum of care from primary care through to secondary and tertiary level, as well as a robust community care network. And now, adapting the quality of care standard. After the WHO quality of care network meetings in Malawi and Tanzania, the Quality Improvement Secretariat of Ministry of Health and Family Welfare, which has established under the Health Economics Unit, took the lead in adopting and implementing the quality of care network in Bangladesh. The process started with the formation of a technical working group to adopt the quality of care framework to the Bangladesh context. Acknowledging the quality gaps across different sectors, the working groups of Quality Improvement Secretariat agreed to take a comprehensive approach to quality of care and expand the scope of the framework to include reproductive, child, adolescent health standard. Once the draft standard were ready, the Quality Improvement Secretariat proposed implementing the standard at the facility level to explore their feasibility and relevance in the country context. The country level adaptation of standard was supported by a number of development partners, including WHO, UNICEF, UNFPA, USAID, the professional association, and other country level experts. Subsequently, Narshindi district was chosen for the pilot implementation of the standards and the tools developed for its implementation. The pilot implementation is led by the various agencies of Ministry of Health and Family Welfare with technical support from USAID through the Mamoni Health System Strengthening Project. Our story will describe piloting process that the Quality Improvement Secretariat and its partner undertook to test the new standard at the facility level in Bangladesh. So, how has this evolved in Bangladesh so far? The focus on quality care has been around for a while. However, this gained momentum in 2015 with the formation of the Quality Improvement Secretariat. As I mentioned already, this is set within the Health Economics Unit and has been a central point for all quality-related activities in Bangladesh. The Quality Improvement Secretariat works in close coordination with the other implementing agencies of Ministry of Health and Family Welfare, such as Director General of Health Services, Director General of Family Planning Services, Director General of Nursing, and Midwifery. There are coordination and technical advisory committees established to facilitate the central coordination and leadership. At around the same time, we developed our national quality improvement strategy as well as the national quality improvement standard. Bangladesh had already started the implementation of every mother, every newborn, that is the EMAN standard in one district in 2016. After the WHO framework was introduced and after the Quality of Care Network meeting in Malawi in 2017, we started our journey with the WHO Quality of Care standard. The National Reproductive Maternal Neonatal Child and Adolescent Health Standard was developed in 2017, and it was decided to pilot implementation of the standard and the tools for its implementation in one district named Noshindi. The implementation of the pilot started early 2018 with a detailed baseline assessment. We'll share more details about this in due course. Regarding steps, what we have taken, we put in place a process to take forward our work in the pilot district. As we have National Quality Improvement Framework Implementation Plan, that is the 5S CQI-TQM. You know that the 5S CQI-TQM is the National QI Implementation Framework approach, and that approach we are also addressing in the selected piloting facilities. We commenced the site selection followed by an orientation of the district managers. A baseline assessment was followed by PDCA cycle, that is plan, do, check, action, to develop the improvement plans. The technical team proposed an independent assessment to identify existing gaps in service delivery. This assessment was conducted by a team from ICDDRB, one of the internationally reputed organization, which is also a partner of the Mamuni Health System Strengthening Project. The ICDDRB team had participated in the Malawi and Tanzania meetings and was well informed about the WHO Quality of Care framework and was supported by a team of research assistants with technical knowledge background and experience in data collection. ICDDRB also had some prior experience of supporting the measurement for the IMAIN initiative in Bangladesh. Regarding site selection, for the selection of the site, we had a number of criteria which we used to determine the district we would like to work in, which would be one out of 64 districts in Bangladesh. We took into consideration the following. Number one, readiness of the facilities. This included the current status of the facility, availability of the equipment, and also cleanliness. Number two, availability of human resources. As this is one of the key challenges in most places, we needed to have a proper understanding of the current constraints and how they are going to overcome them. Number three, proximity from Dhaka, the capital city, for close monitoring and supervision. And finally, we also focus the interest and commitment of the facilities to improve the quality of services. And this is the most common element of any piloting and any facility for improvement of the quality of care. In line with this criteria, we selected 4 facilities for the processes. District Hospital, which is 100-bedded, managed by Director General of Health Services. Second, Mother Child Welfare Center, which is 20-bedded and which is managed by the Director General of Family Planning Services. And there are 2 facilities in the sub-district level. And each facilities are 31-bedded, named Polash and Shivpur Upazila Health Complexes. And both of the facilities are managed by Director General of Health Services. This is our first learning, understanding the environment before we start work. So this is the scenario of the district hospital, named Noshindi District Hospital. Let me introduce the district student for the pilot implementation. This is within the division of Dhaka, which is the capital also, and has a population of about 2.2 million. Within the district, there are total 6 upazilas, total 6 sub-districts. There are 3 facilities at the district level and 5 at the sub-district level. For this pilot, we selected 4 facilities: 1 district hospital, 1 mother and child welfare center, and 2 Upazila health complex that is situated in the sub-district level. Okay. So first, what we taken in the initiative as implementation plan, that is the orientation of the district manager. We arranged a number of sessions to orient the district manager throughout the district of North Sindhi on quality of care. It started with sensitization meetings and district manager on quality of care piloting in North Sindhi. After that, the process included specific development of capacity as well as the general overview of the session. It was really positive that our district manager were engaged and really motivated to participate and extend their knowledge to improve the care of outcome. These events are typically held in the North Sindhi and included multidisciplinary team. Regarding baseline assessment, what we conducted earlier, to begin our work, we need to undertake a baseline assessment, which is conducted by ICDDRB team. A detailed assessment plan was initially developed, and which we would provide an in-depth understanding on all of the 8 standards of the WHO framework. The manager and service provider from these facilities were well-oriented and sensitized about the assessment, and they facilitated data collection where feasible. And at the same time, the assessment comprised of detailed facility readiness assessment, direct observation of the maternal newborn care services at outpatient and inpatient areas, client flow analysis, exit interview conduction, and secondary analysis of the service statistics. It addressed all of the components of quality care network, like provision of care, experience of care, patient outcome, and related to some maternal newborn health. The tools used for some of the earlier assessment in the country, including Bangladesh Health Facility Survey, Women Baseline Assessment, Exit Interview, etc., which are reviewed and incorporated as needed. Regarding some core indicator and tools, we used a set of core indicators which would be used to measure performance of our work that we are going to piloting. The table shown on this slide is an illustration of the type of core indicators chosen and methodology used for collection the information based on this data. The core indicator for the initiative, however, includes other quality of care indicators as well. We developed a comprehensive approach for this, which included documentation of the data collection process, the tools that could be used to collect data, and finally, sources of data. Now, I hope to introduce Dr. Najma. She's the consultant of our district hospital. Now, she will continue next of the slide.
Thank you, Dr. Aminul. So, how did we adopt the quality of care standard? So far, we have focused on the pre-work, which is essential for successful outcome. As we move ahead, we will share with you how we have applied the standard in North Sindhi. In PDCA Cycles Started, following the sharing of baseline assessment findings with the facility teams, each of the facility methodologically identified the priorities area by using matrix diagram for them to start the improvement cycle with USAID's Mamoni Health System Service Strengthening Support. These improvement areas were then developed into detailed PDCA, that is Plan, Do, Act, Check and Act cycle, to systematically implement and measure the intervention's outcomes. Based on the baseline data, we were able to summarize the priorities area as follows by facility, such as antenatal care, labor monitoring using Partograph, administration of oxytocin as part of active management of third stage of labor, essential and immediate newborn care, maternal complication management, and sick newborn management. Then district hospital at a glance. Here are some statistics of the district hospital to have a glance of the facilities. Number of beds 100, bed occupancy rate 150%, number of doctors 16, number of nurses 43, service available antenatal care, postnatal care in 24 hours 7 days, emergency obstetric and neonatal care, CANU, IMCI, family planning, and health education. Number of delivery from January to June 2018 to 72. Among them, normal 174 and cesarean section 98. Number of antenatal care from January to June 2018, 4,878. All of us know that for quality antenatal care services, a couple of areas need to be addressed. For example, practice like health education, counseling using visual aids, documentation of antenatal services, discussion with the clients on health examination findings, taking permission before any procedure, which is a part of respectful care, are extremely poor, in some cases absolutely nil. Similarly, use of episiotomy is 22%, which was relatively high, and the Partograph used for labor monitoring was also absent. Similarly, quality postnatal care comprises of temperature measuring, taking perineum for wound, urine output, and bowel movement, and assessment of newborn health condition are also absent. The practice of most components of immediate newborn care was low. For example, early initiation of breastfeeding within 1 hour is low. Skin-to-skin contact just after delivery needs special attention to acquire spontaneous practice. The district hospital did not have any kangaroo mother care services for preterm babies. The district hospital is currently in the process of setting up a KMC area. During a PDCA workshop, improvement teams were formed according to the service component prioritized. Each improvement team review and reflect on the gaps identified through the baseline assessment and did a prioritized exercise. For each prioritized problem, root cause analysis was undertaken using the fishbone diagram. This analysis helped the team to come up with actionable steps for addressing the root causes. Timelines for implementation and measurement parameters were identified for each area of improvement. The team also agreed on the methods for regularly measuring or monitoring the progress on the improvement areas. In some cases, it involves simple modification to existing service records. In a few cases, setting up new record keeping or a simple data monitoring chart for easy visualization. The PDCA cycle in district hospital. Let me share with you a summary of what we did at the district hospital. The improvement action plans also require a number of inputs at the local level. Competency development of the doctors, nurses, and support staff was one of the major inputs. The staff received competency-based training by the professional bodies on a number of clinical areas such as quality and antenatal care, labor management using Partograph, immediate and essential newborn care, avoiding harmful practice during delivery, and lastly, respectful care to the mothers. In the next few slides, I will show you some of the early success that the facility has achieved in improving the quality of care. Some of the other inputs to the hospital included the provision of essential equipment and supplies, such as ensuring the availability of Partograph in the delivery area and counseling materials at the antenatal care area. The hospital regularly organized WIT or QI meetings to review the progress of implementation and to monitor the changes as recorded in the monitoring tools that each team has been using. So, use of Partograph in district hospital. As we can see from graph, we see a Partograph at the district hospital has improved tremendously following the plan, do, check, action cycle. Partograph were used in monitoring the progress of normal delivery. Immediately after the PDCA rolling and the subsequent competency-based training, the use of Partograph rapidly increased. The practice was reinforced through routine supervision and through the work improvement team. During implementation phase, some points of action were identified to practice on a regular basis, such as Partograph paper should be attached within the patient treatment form. The Partograph will be used for all active labors. Concerned service provider will plot the form independently or in consultation with other trained personnel as in case of difficulty. Partograph paper will be available by facility managers. Some essential equipment were made available for monitoring maternal and fetal well-being through Partograph. The regular recording and review of the data also help the service providers to ensure increased use. The form WIT checked the overall practice and act accordingly. Since a number of women come to the district hospital when the labor is imminent, the Partograph use could not be ensured in all cases. Some of these cases were referred from the lower level facilities. On an average, the district hospital conducts 45 normal deliveries each month. In addition, 50 deliveries are conducted by cesarean section, most of which are elective cesarean section.
Okay, thank you, Dr. Najma. Now, I would like to share with you of our few success after starting the implementation of the piloting. Regarding administration of oxytocin within 1 minute of birth. The administration of oxytocin as a part of the active management of third stage labor is an important indicator for us here in Bangladesh. It demonstrated the adherence to the clinical protocol at all facilities where deliveries are undertaken. As we can see from the graph above that there was stability in the process following the intervention. Our baseline in Narshindi varied from between 20% at some facilities and 100% in one facility. What we wanted to see in a stable process, we can see from the graph that following intervention there is stability in the process. This is an example of how the PDCA process could assist the service provider to rapidly change their practice with some external facilitation and support. Another important slide regarding babies born alive receive immediate and throwing drying after, and this is another indicator related to drying immediately following birth. In regard to this intervention, there was quite a bit of variation among different health facilities types. However, after the intervention, a consistent practice trend was noticed across all of the health facilities. Regarding the slide of babies born alive receive immediate skin-to-skin contact. Regarding skin-to-skin contact just after birth is another indicator to ensure thermal protection of the newborn. We have achieved significant improvement in this area after the implementation of the PDCA cycle at the facilities. However, some facilities were yet to achieve consistent high coverage of this intervention. We have recommended a second round of PDCA for identifying the root cause of this suboptimum practice in some facilities and act accordingly. Regarding the slide, babies born alive with the facility breastfeed within the 1 hour of birth. And finally, the early initiation of breastfeeding within 1 hour of birth, and experience of care indicator. Again, post-intervention, we are at 100% in this indicator in all facilities. Monitoring of the indicator over a few months will demonstrate whether this has become a part of standard of routine practice. And the challenges during our implementation of the piloting model. Still, there are some challenges that we are facing from the beginning. Today, we have demonstrated how concerted effort in the quality improvement lead to improvement, which will hopefully be sustained in the future. However, we do have some system challenges which need to be addressed. Without addressing this, we are at risk of not being able to sustain the improvement that we have made. The challenges in North Sindhi district, the piloting facilities are as follows that you are seeing in the slide. The topmost challenges that we are facing from the beginning, that the retention of the trained personnel and leaders in the selected facilities. That is the key most challenges for the piloting intervention side. And definitely there is a huge load of work, and definitely the service provider has faced a lot of service load during their working time. And monitoring and supervision by internal and external teams, this is one of the key challenges for our piloting period. And at the same time, strengthening the physical facility for quality of services. And definitely, we should have to address the uninterrupted supply and maintenance of the equipment. And inventory and storage facility, one of the other challenges. And also there are some challenges regarding some resource mobilization for some minor QA activities from government side or the public health facilities. And this is a model of expanding the reach of quality improvement, and the early success from the implementation of the quality improvement pilot in the district hospital gives us the confidence to further expand the initiative to other facilities and districts. It is definitely a long journey for Bangladesh, which has recognized significant gaps in the quality of health services available across the country. So, as we move ahead with the goal of expanding quality improvement in Bangladesh, we need to take into the account the following. Number one, innovate and design intervention that addresses the challenges. Number two, build a capable workforce and ensure that there is a capacity to address the challenges. Number three, quality is not an ad, and also to integrate quality into the overall health system approach. And finally, share lessons, spread and scale up. And finally, I'd like to thank you for listening us today. We hope that by sharing our knowledge and experience from Bangladesh may be some value to you. For Bangladesh, we continue to work through GOB and with our other development partners to make the sustainable improvement to quality, which means that our patients get the best care possible. Using the WHO framework as the basis, we have been able to share some of our experience in the district hospital. I take this opportunity to thank all our partners and stakeholders who are supporting the quality improvement initiative in Bangladesh. Our special thanks to USAID and the Mamoni Health System Strengthening Project for their technical support for the adaptation and implementation of the WHO QAC network for the continued commitment and expand this initiative in Bangladesh. We now welcome and question that you may have. Thank you once again.
Thank you to both speakers. This is Benedict speaking again. Thank you, Dr. Hassan and Dr. Nazma. We have a few questions for you from the participants today about some specific aspect of your presentation. There's a question from one participant before you presented the initial results on why you think the Partograph has not been used before you started the PDCA cycle or not used enough.
So, Wendy, could you respond now?
Yes, please go ahead. Yes.
Yes, Dr. Nazma will respond.
as Partograph not used initially for lack of motivation, and mothers are come at a later stage when there is no time of doing Partograph, and also not used due to not awareness, and paper was not supplied in facilities.
Okay, there's another question related to the use of Partograph. Now that it's being used and then the use of Partograph increased drastically, do you think it will help to reduce the C-section rate?
No, Partograph is a paper which assess the labor status. If labor conduct normally or cesarean section, so Partograph used properly, normal delivery contraction level increase, and also cesarean section rate also decreases. And
okay, a very good question about how you implemented the initiative and what you've learned from it. What do you think the QI Secretariat and Mamoni can share with other countries which are trying to implement similar initiatives? And most interestingly, what not to do when you try to implement such a program for quality improvement? What is your key lesson? What you would recommend people not to do?
Well, Benedict, the key challenges for not to use the Partograph and the key challenges of quality of care is the motivation and ownership failure of the service provider. Actually, the service provider of my country at this level are not well motivated to use the Partograph, and they are not well concerned about the proper utilization and at the same time the improvement the quality of care. So once we would have able to motivate the service provider and take the leadership appropriately, then definitely the Partograph will be used for the improvement of the quality of care, and at the same time the normal delivery will be increased and the number of cesarean section will be decreased. So I think that if we once we have tried to introduce the increase the motivation of the service provider, that is the key challenge area. So I think that in course of time, at the same time we have to address the shortage of manpower and shortage of AHR. That is one of the key area, and that's why in spite of the good leadership and motivation of some places, then they would not be able to continue the work for using the Partograph. That's one of the key challenges. So we hope that definitely in course of time in future, we have to address the challenges regarding shortage of HR, and at the same time we have to more focus to development the skill and ensure the motivation of the service provider for ensuring the Partograph and for improvement the quality of care.
Thank you, Dr. Hassan. There's a question about the type of challenges you were facing. That seems to be a lot of system challenges, which are beyond the control of the facility. So how did the district help?
Sorry?
How did the district help at the district level?
Actually, the challenges that the facility are facing, actually most of the challenges are system challenge, and we are trying to address or we are trying to minimize the challenges by add the additional manpower and by increasing the leadership capacity, by increasing the motivation of the service provider to minimize the gap of the challenges. So at the same time, we are trying to provide more manpower from the centrally to fill up the gap and to overcome the challenges in course of time.
Okay, thank you. There is a question about your quality improvement team. So how did you select people for the quality improvement team? Were there people who were non-health staff?
No, all of the people are the health staff, because we have several teams in the district hospital as well as the sub-district health facilities. The team, there are several work improvement team, Actually, this work improvement team are from physician and other paramedics. I mean the nurses and medical technician and other supporting staff. And each team composed of 6 members. And we are trying to develop the capacity of the team for 5S and PDCA, and at the same time we are putting extra emphasis for monitoring and supervision activities for quality improvement, focus of the team.
Okay. There are many questions on how you're going to sustain this after the pilot phase, and one relates to midwifery and the midwife, and how do you motivate them to stay in the health center? That motivation would not be enough. So how do you motivate them to stay, and how can you sustain the work that you're doing after the pilot?
Definitely, it's a big challenge to sustain. To sustain is the key challenge any of the piloting initiatives, and the underlying challenge of this area, that the shortage of HR and improper leadership. These are the key 2 areas that we have identified to sustain any project. So our government already has taken the initiative to increase, to deploy more manpower, especially physician and nurses in the health facilities. We are expecting the lot of physician and nurses will be employed in our health facility in course of time, and at the same time the motivation and leadership skill of the service provider will be developed, and we would be ensure we hope that we will be able to sustain the activities in course of time by introducing these 2 core elements in our health facilities. And at the same time, we will share the knowledge and lesson learned to the other health facilities that will play a vital role for sustaining the mechanism in countrywide. And definitely, at the same time, the working environment will be improved by increasing the supply of equipment, by providing the training of the service provider, by enhancing active monitoring and supervision to the service provider. We think that by introducing all of the elements in the health facility, we would be able to continue our sustaining mechanism in course of time.
A related question about sustainability is how you keep the staff motivated after the improvement once the problem that the PDSA was looking at is addressed.
Actually, that there are several ways to motivate the staff globally. That is one is the financial incentive, and other is the non-financial incentive. Actually, initially we are trying to focus on the non-financial incentive modality. That's why we are trying to introduce some award, we are trying to introduce some certificate, we are trying to praise at the working area that they would be able to work more. And in course of time, we have a plan to introduce some financial incentive for invite more motivation of the service provider. So right this moment, what we are doing, we are focusing basically on the non-financial incentive modality.
Okay. A question about what now? Are you planning to do an end-line assessment at some point?
Definitely at the end of the pilot, we will conduct an end-line survey, and this survey, would be able to measure the changes for the piloting intervention, and it will be a big learning for us to scale up the RMSS piloting in other health facilities. And definitely we could be able to learning experience, we could be able to add the lesson of the end-line survey, and definitely the rest of the facilities that we are planning to scale up will be added the learning lesson to that facilities in course of time.
Okay, I have a follow-up question after you answer on midwife and how to encourage them to stay. from a midwife online who said that training is not enough and that a clean and safe accommodation for the midwife is needed, together with respectful working relationship among the team of midwives. So nurses and doctors, do you have any things to say about this, about the working condition of midwives?
Definitely, you correctly mentioned the reason and issues and areas. So we think that at this moment, what we are doing for increasing the good working environment of the midwifery, and we are trying to focus on for the development of the capacity and better working environment. You know that we are introducing the 5S approach for improving the good working environment. So we think by adapting the 5S approach in the working area, we would be able to improve the working area of the service provider, not only service provider, at the same time the midwives of the facility. And they will feel more encouraged for conducting the normal vaginal delivery and regular follow-up of the antenatal checkup. That will be much more essential for safe delivery and safe that will increase the maternal mortality in course of time.
Okay, you've got a few questions relating to the setup of facilities in Bangladesh in general. So one question is about whether there are any baby-friendly hospitals.
Sorry?
One of the questions is whether there are baby-friendly hospitals in the country.
Yes. This is the baby-friendly hospital.
Okay. And another one also about the setup is whether there is enough facility to manage obstetrical emergencies.
Yes.
Management of obstetrical emergencies in the facility, whether there are enough facilities that can do that.
Yes, we have enough facilities to manage the obstetrical emergencies in our district hospital.
Okay. Another question specifically about the district. The district of Nasingdi that you talked about is one. I suppose it's PDCA. There's some typing difference here. One PDCA is addressing one. Yes, okay. One cycle is addressing one problem. In this case, it was oxytocin in a minute. Or is one PDCA cycle trying one solution for one root cause of a problem? So basically, one PDCA to address one problem, or one PDCA to try one solution for one root cause of the problem. How did you organize your cycles? Did you get that? So that was relating to the example you gave of the Nasidi district. And that person wants to know if every PDCA cycle was addressing one problem. In this case, it was or looking for one solution to that problem.
No, one PDCA solution is by one problem.
Actually, what actually we have shown in the slide that the each problem focus, each PDCA for each focus on each problem. PDCA focus every one problem, one PDCA, one problem, one PDCA. The focus a problem-based PDCA we have developed, and we are practicing and we are continuing the PDCA for problem solving.
Okay. Another question of sustainability. I think you raised a lot of questions on how to continue this good work. Given that you have limited data points, what are your strategies to sustain the improvement before you move on to new areas of intervention?
Actually, Benedict, these are definitely challenging. You know, to continue sustaining the PDCA that we are planning in course of time, the model will be scaled up countrywide. Definitely, it's a big challenge from our side. And the challenge that I mentioned earlier, that the HR and other leadership issues that we are struggling from the beginning. So I think that in course of time, we'll be able to address the challenges, especially the HR and the leadership of the service provider. And in this way, we'll be able to continue the PDCA activities in other facilities while we will be scaled up in course of time.
Thank you very much. These are all the questions I've had for you. There was quite a few at this point, so I'm giving the floor to Zainab again.
Thank you, Ben. Thank you, Dr. Amino, and thank you, Dr. Nazma. It's a very interesting discussion, great questions, and it was very interesting to see the timeline in the start of the presentation and follow how the efforts have intensified since 2015 when the QI Secretariat was established. What I would like to note is to see that strong leadership that has been provided by the government through the QI Secretariat, but also how it's been supported by a strong partnership at country level, not only by development partners, but also involving strong local academic institutions that can support the implementation work and also document a lot of these experiences. And as we saw through the questions, is that there are increasingly more coming out that there are system challenges, and it seems to be some of the biggest barriers to delivering quality services. And I think we need to understand more about how district and national leadership and the systems that support this can help solve these often complex problems. But I would like to wrap it up by saying that we remain encouraged, and we do see from the presentation that the core indicators showed great improvement only over 6 months. So questions around sustainability remain, but I think the more we can document and learn around it will be to great benefit for all of us. So thank you again to our speakers for sharing their experiences. We look forward to learning more as you go ahead. Thank you for excellent questions and the moderation, Bena. As usual, I would like to remind you that the recordings of the webinars are online in case you had problems with the sound today. And the website is qualityofcarenetwork.org. And please do share these webinars with your colleagues that are interested in quality of care and want to learn from the implementation experiences of others. And Ben, if you want to say something about the podcast for people who are still online.
So we also, so the webinars are a way to present quite formally to this audience, and everything is online. The presentation will be online, the recording, your question, your answer will be online. But we also have a podcast called Quality Talks, and we interview health worker and health manager about their personal view and experience of running or implementing quality improvement initiatives. So we are always looking for good speakers. If you have an idea that you want to share, a presenter that you want to recommend, please write to me. And here is my email address in the chat. And write to me, and we will interview that person and share the story with you. I will also send the link to the Quality Talk podcast online, and you can find all this on one place at qualityofcarenetwork.org. That's it.
Great. Thank you.
Thank you, everyone.
Thank you.
Thank you very much. Bye.
Thank you.